Hello and welcome, and apologies for the technical difficulties. Welcome to the CCH Housing Equals Justice Conference. We are delighted to have all of you here today at this conference and are pleased to welcome you to this current Critical Time Intervention and Rapid Rehousing Programs workshop. We have some great speakers with you today, so are really excited to have everybody here, and thank you for joining us. So a little bit about Housing Equals Justice. This is a campaign that CCH started to bring together the topics of racial justice, criminal justice, and economic justice as they relate to homelessness. And we are exploring a lot of different topics that are really current in the field right now, including the impact of COVID on homelessness. So hope that you're all taking advantage of these wonderful sessions. So a little bit about the conference. First of all, we've just really had wonderful speakers and hope that you've visited the conference website, which includes a wonderful new Housing Equals Justice store that you can visit to check out some t-shirts, masks, and mugs that you can buy, and all of the extra funding from proceeds go to the Housing Equals Justice campaign. And really thrilled to thank our sponsors, of course, Bank of America and Zillow, who really have made this whole thing possible. We couldn't be more grateful to them for making it possible for us to offer this conference free of charge to all of you. So delighted to have all of you here, and thank you for joining us, and thank you to our sponsors. And now I'm going to hand it over to Amber, who is going to introduce our speakers. Amber?
Yes, hello. Our speakers for today, we have Carolyn Hainsworth joining us. I don't see your screen, but we have Carolyn Hainsworth joining us. Jessica Kubicki, who is the Director of Programs at Supportive Housing Works, and we have Randy Grant, who is so all three panelists are joining us. They are all great, and they're going to talk to critical time intervention and have been implemental in inserting CTI in the rapid rehousing programs in Connecticut.
Hi, everyone. Welcome to our workshop. We're happy to be here. Like Amber said, my name is Carolyn Hainsworth, and I'm going to start us off and sort of talk about actually what we're going to talk to you about. I know the title of this presentation is Critical Time Intervention and Rapid Rehousing Programs. It's really about a specific set of programs that we implemented in your state, in Connecticut, including in Jessica and Randy's organizations. And I'm so happy they're here with me today. Again, it's so good to see you guys and work together again, because we have a history together of implementing this program over the course of really 3 years. And it's so exciting now to be in a place where we can look at some of the outcomes and see how they're doing, 2 years since the end of the program. So with that, I guess if we could start the slides. Yeah, so again, this entire presentation is really going to be sort of, I guess, 3 or 4 part. I'm gonna present to you a little bit about the background of CTI for rapid rehousing, the pilot study. And I know as we get into it, Jessica and Randy are gonna talk to you about what CTI is, what rapid rehousing is, how it fits together, how they implemented this program into their organizations, the lessons they learned, and the outcomes that they're seeing now. So, so just to kind of kick it off, why did we embark on this project? So, as you all know, and we're going to kind of go over it a little bit, rapid rehousing really has 3 components, right? It has financial assistance, housing placement, and case management. And what we realized a few years back is that the case management strategies for rapid rehousing recipients were really just kind of all over the place, to be honest. As we all know that have worked in human services for any length of time, there's a lot of different approaches for case management. Some are truly just very vague and hard to measure. And so as, you know, it was really the National Alliance to End Homelessness that initiated this project together with the Melville Charitable Trust. And we'll talk about our partners for the study in just a minute. But really the NAEH was really eager to learn, you know, what case management should we promote? What should be the strategy for rapid rehousing? And that's when they approached us at the Center for the Advancement of Critical Time Intervention at Hunter College in New York to really help create an adaptation of CTI for rapid rehousing. So, you know, the whole point was to establish a new model, a best practice model for use with rapid rehousing to be employed across multiple settings, populations, and locations. So a little bit about CTI real quick. CTI was originally developed in the late 80s, early 90s in New York City. The developers of the model, Sally Conover and her husband Ezra Susser, really observed in their work in the field that severely, persistently mentally ill single adult men were being placed in housing, were returning to shelter at an alarming rate, as you can imagine. And this was a time in New York City where there was quite a bit of homelessness was on the rise. Inequality was, you know, it was really the beginning of the diminished welfare state that we see today. And so they set, what happened was that they noticed the discharge planning that people would have at the end of their stay in institution, whether it was psychiatric care or homeless shelter, was just not enough to help people really transition to the community. So CTI, they developed CTI as a way, it's really, I call it a bridge. It's a bridge, it's a set of services that connects people meaningfully and profoundly to the resources that they need to become established and stable in their community. And for every person, that's different. And so CTI workers, you know, are adept at really focusing their work on what that person needs to be connected. Okay, so we can go to the next slide. So this was really the first attempt in Connecticut to adapt CTI for rapid rehousing. So as I mentioned, you know, CTI was originally created for more of a supportive housing population, I would say, that had more wraparound services. CTI for rapid rehousing is really quite different, and we'll get into that in a little bit. But in general, this was a, you know, I said 3 year, I guess it felt like 3 years. It's really like 2 years. But a project that you can see the partners there listed: Connecticut Coalition to End Homelessness, the Melville Charitable Trust was our funder, NAEH, Connecticut Department of Housing, Center to Advance Critical Time Intervention at CUNY, and then various provider agencies in Connecticut. Actually, we started with 13 agencies. Many of you who are with us on this workshop are likely from those agencies and are sitting there nodding, going, yes, we were there, we know all about this. Yeah, and so the bullets there just kind of walk you through what we did. We started with a very, you know, in the beginning, it was just me kind of doing the literature review, trying to find out what was working in rapid rehousing programs across the country. Came up with really nothing. There was no data. People were not really reporting the kind of case management they were using. Nobody was using CTI to our knowledge. So we started really from scratch. You know, it was really a trial and error. You know, we built the model and then we trained these agencies in it in a matter of days in the winter. They took off running with it, and we provided technical assistance and consultation throughout that summer into the winter. And then the following year, we did fidelity reviews. And the fidelity reviews really showed us that, you know, a very strong response, you know, that I would say the best, you know, fidelity review is not, it doesn't tell us if the population is benefiting. It just tells us to what extent the organization has really implemented CTI correctly. And I can say that, you know, all of the agencies that we assessed were doing quite well, you know, scoring very high in that area. So I will turn it over now. I'm not sure who I'm turning it over to. Maybe Jessica. I think it's
Yes.
Jessica. Yes.
Awesome.
Thank you.
Thank you. Hi, everybody. I'm Jessica Kubicki. So before we dive into the implementation of CTI, let's just go through what is rapid rehousing first, and why CTI goes hand in hand with rapid rehousing. So there's three main components for this kind of housing intervention. The first is housing identification. The idea is whether it is the rapid rehousing case manager or a very specific housing coordinator, there is a person who is helping the identified household look for safe and secure housing. How do you engage the landlords? How do you sell yourself to a landlord, right? So a lot of these clients may have some barriers, and this could be the first time that they're renting. So, you know, we have trained staff to assist the clients in finding a unit that is affordable, that's in the location or community of their choice, and ideally somewhere that they can become completely self-sufficient and be able to remain, hopefully, on their own at the end of the program. Next slide, please. All right, so component number two, the financial assistance. So the program up front covers all of the security deposit and the first month's rent. After that, the case manager is working with the household on how much they can pay towards rent, with the program kind of covering the remainder of it, with the idea that each month the client's rent portion is increasing while the program's portion is decreasing. This gives the client a variety of different kind of opportunities, right? So number one, we cover the upfront costs with the hope that either a client is able to secure furniture or turn on utilities if we aren't able to provide financial support for those. And it also allows the client to get used to making rent payments, and it removes the like cliff effect, right? For having to have to pay no rent to paying all the rent, and just learning how to pay a little bit more each time. And next slide. All right, and then the last piece is case management. And so case managers are kind of assigned to the client to work with them, and it's based off of the needs of the client, but our goal is we are looking at this client holistically, right? So yes, we are focusing on their housing and focusing on being able to have them afford the unit ongoing, but we're also working on ways or identifying the barriers so that they are able to get to that place. So some of that includes employment, benefits like healthcare, or if they need cash assistance, things of that nature, whatever is able to get resolved so that clients are able to, you know, maintain housing ongoing. All right, and I'm going to turn it over to Randy to talk about CTI now.
Thanks, Jessica. So just really quickly, Randy Grant, program manager at New Reach here in Connecticut. So the next phase of our presentation here is to talk about the points of how we implemented CTI into rapid rehousing, so just a quick overview of critical time intervention in rapid rehousing to start. So there are actually two different models for CTI that have been utilized widely, but we decided on the 6-month model. Actually, I would say DOH decided on a 6-month model, and there's 3 phases for CTI, and each phase is the same duration. In this case, 2 months for phase 1 and 2 and 3. For a 9-month model, it would be 3 months for each phase. Another large point, of course, is decreasing contact over the course of those phases. So we're really heavily working with these families and individuals in the first phase, establishing rapport, and also in pre-CTI, which we'll get into, but establishing rapport, understanding what their needs are, assisting them in achieving their goals and providing resources. And then over time in phase 2 and phase 3, we're trying to decrease that contact so that they can rely more heavily on the supports that they have or that we have connected them with. Another piece of it is small caseloads, utilizing a weighted caseload tracker. So one of the main issues I had as a caseworker, which I think is very common for service providers, when I first did case management, I had a caseload of 30 people, and that caseload was never ending. So I provided services for people in a permanent supportive housing complex, and I served 30 of them, and all 30 of them were very involved, and it was really difficult to sort of give them each the attention that I felt like they needed at any given time. So CTI really focuses on small caseloads, utilizing a caseload tracker that gives each phase what we call a standard caseload equivalent, which decreases through the phases so that you're spending more time with those in the beginning phases than those in the later phases. And of course, it's community-based, meaning we spend time visiting with people in their homes, in their own environment, but also in their community, which is really important. Community can really be a huge benefit to someone, or it can also be a challenge, but exploring their community with them and familiarizing themselves with it and helping them familiarize themselves with it is a huge part of CTI as well. So some of the core values, one of the things I really like about critical time intervention is it incorporates other evidence-based practices that have been widely used and have been studied and have been shown to be very effective. And I would say, most people that are doing case management are familiar with these kinds of strategies and utilize them widely. We, of course, in CTI, they become a core components of what we're trying to do. The first of which being strength-based and client-centered, which of course we really want clients to be the driver of the services they receive. We want them to determine, what their service plans look like, the goals that they're trying to set. They have a right to self-determination. Also, a large focus on empowerment and sharing every decision that gets made with them. So it's not a service where we're telling clients what they need to be doing, what their goals need to be, and how we think their service plans should be created. So very large and important point there, so that they're involved in the process, which lends to a better discharge when they're feeling a bit more stable and have a higher level of self-sufficiency. It is a housing first based model, which has its own 2 to 3 day training. But the idea, of course, behind housing first, it's really difficult for people to make progress in other goals and things like sobriety or income or other things that they're trying to achieve without first having the stability of a place to live. So the housing first model is incorporated into CTI Rapid ReHousing. Motivational interviewing, of course, which is not a strategy to get people to do what you want them to do, but to identify what their goals are, help them identify those barriers and work with them to overcome them. Very trauma informed, very important piece of what we do. We don't want to re-traumatize people or bring up past trauma as we're working with them. So we need to be educated on what that looks like, educated about how we meet with people, the space in which we meet with them, and just being very careful and being very aware of the things that they have gone through. One of the things I always say is homelessness in and of itself is a very traumatic event. And pretty much everybody that comes into the homeless system has faced that trauma. And so we need to be very, very careful with how we approach that. The services are individualized, meaning, of course, that the program never looks the same for two people. It's always based on the needs of the person or the family. And the services we provide are very transparent. And what I mean by that is we are very clear with the timeframes of the program. We're very clear with what we are able to do, what we're not able to do, and that we really start planning discharge from day one. So it's very clear that this is not an ongoing program, that our touch is is relatively light, and it's maybe very different from other kinds of case management that they have experienced in the past. Then the other value, one thing I will mention really quickly, Jessica and I were actually have worked previously in a community where CTI was being utilized, sort of separate from the subsidy that they were receiving. So we were providing the services or overseeing those that were providing the services. And we have done the rapid rehousing implementation as well. So we've seen both sides of the system where rental assistance is part of the CTI and where it isn't part of the CTI. And so we've actually had experience in seeing various agencies implement this at varying degrees of commitment to the CTI model. And one of the things we became really clear is fidelity to the model is very important for it to be an effective model. There are, of course, pieces of it that are useful in any case management setting. And I think that, pieces of it can be utilized, but to have a more effective model following the fidelity of CTI is really important. So next slide. So very, very key component of CTI and rapid rehousing is the supervision that takes place. One of the things we have seen in overseeing this in a few different communities is sometimes there were agencies that didn't have supervisors involved. It was just sort of one caseworker doing the work, and we'd hear them talk in the meetings and sort of express a lot of the difficulties that entailed. That just trying to do it yourself as opposed to having a supervisor and a supervision team that assists in implementing CTI is really, really helpful and makes it quite a bit more effective. So weekly supervision, individually or in team supervision or group supervision is the preferred method. Of course, if you only have a supervisor and one individual doing it, that would just be the two of you. But it encourages really a team building approach and team sort of approach at addressing all the issues that come up, but also celebrating successes and working together to address the needs of those whom we're serving. It creates bonding amongst the staff who are doing CTI, and of course, just joint problem solving and support. So when supervision takes place, there is certain things that need to be focused on in a CTI setting. So those things would include case presentation of all the new clients that come into or that become part of those whom you're serving, who get enrolled in the program. Review of clients who are being discharged or transferring from one phase to the next is really important to make sure that we're discussing what happens when you transfer to the next phase or what should be happening when they discharge, the conversations you should be having and the things you're working towards. Reviewing of clients in crisis, which anyone who has done case management in teams, crisis tends to dominate the conversation quite a bit, and you try to work as a team to address that crisis. But that shouldn't always be the only thing you discuss in these meetings. It needs to include these other things as well. Review of successes and positive change, of course, is very important for morale, and celebrating those successes is just as important, in my opinion, as dealing with the crises. Occasionally reviewing your entire caseload, which can be difficult if the caseload is very large. But the idea here is that every person on the caseload has some team time and some discussion in the team setting. And then, of course, continual review of CTI principles, which I'll get into a little bit more later. Next slide. So the mindset for CTI. So another thing that Jessica and I were really, really privy to when we did this, geez, I guess that was 5 years ago, Jessica, 6 years? Yeah, 5.5 years ago-ish.
Yeah, it was like 5 years, yeah.
Yeah. When we first started doing this, CTI was kind of new to both of us at that time, and we kind of grew together in our knowledge of it, which was fun. But the first thing we noticed is it really can be kind of a difficult strategy for those who have done what we'll call just sort of typical case management or case management that that is done, you know, over a long period of time, and there's really no end date to it. So there's really a change in mindset that needs to happen, and embracing kind of a new strategy, because some of the things that are done in CTI are very different, as I said, from what is done in other kinds of case management. And so really having somebody who's trained in CTI, somebody who understands how it works, is very important to sort of cheerlead it, or at least educate about why this strategy is effective and how it's effective, and to just sort of allow those who are utilizing it to give the full fidelity of it a chance. We did see those, you know, those who were able to follow the model to fidelity, but we also saw those that kind of took pieces of it and tried to do the pieces that they really wanted to or agreed with, and then sort of leave the other pieces that they didn't understand aside. And we saw that it really wasn't very effective in that sort of scenario. So adjusting from clients needing ongoing case management to more intensive and less time enrolled is kind of the point of one of the main points of difference that we're doing in case management strategy. The next bullet point. So the other thing that we really needed to remind people and educate people on is it is an evidence-based practice. It is an evidence-based practice, excuse me. And it's been widely used. It's actually being used in Europe, South America, all across America. It has been used. There's been studies on it. The more I follow Carolyn's CACTI website, the more I see what's being done with this. It's been used with a lot of different populations. So one of the things I hear when I've trained on this in the past is this: it sounds like this could work for your population, the people you're serving, but for our people, it won't work. You know, it's just not, it's not going to fly. We're not going to be able to, you know, do a 9-month model with them and then disengage. They have too many barriers, and their need is too high for that. So the thing we educate about is that it has been used with those. It was even begun with people with severe and persistent mental illness, chronic individuals, homeless individuals. It's now has several iterations with the domestic violence population. So the idea is that you know, give the fidelity of the model a shot, and you'll be surprised at how effective it works. And if you try to take bits and pieces of it but not really follow the model, we really did see that it's not an effective model in that kind of case. So just an important piece on the mindset there. So the benefits that we first identified when combining CTI with rapid rehousing, some of them were very apparent and some of them were very clear. We wanted to make sure we talked about those. The first thing is it's a really good fit. So you have a time-limited rental assistance program matched with a time-limited case management strategy. So both of them work to support each other, and you're both working to discharge the client from services from the first day, from day one, so that they're supported, they have what they need, and you're working, again, to achieve that from the first time you meet with the client. The other large benefit, which I discussed previously, is manageable caseloads. Following CTI to fidelity means you don't exceed a certain weighted caseload. You don't exceed a certain number of clients. You don't exceed your ability to serve the clients well, depending on, you know, which phase they are in CTI. And it also, the other benefit, of course, is just assisting clients to get the resources and skills they need to succeed without ongoing case management. So rather than sort of being that case manager that's always there, you're their primary support, you're the person that's really helping them with everything that comes up. The program is designed to connect them with longer term supports and with people that can assist with those needs with you phasing out. And so this is where I'll turn it back over to Jessica to talk about our challenges that we experienced.
Thanks, Randy. Yeah, so obviously it would be naive of us to think that there wouldn't be challenges when implementing a new program. So some of the challenges that we had experienced, and I think kind of across the state as well, so lack of agency capacity to provide the needed supervision and oversight. And we're going to go into more detail, so I'm just going to briefly go over these. Community and client traditional expectation of case management, so kind of moving away from that mind frame of what case management looks like. Combining rapid rehousing with CTI and why it makes sense, but when that initial thought process kind of came in, it was like, no, this doesn't work, and how we were able to kind of meld the two together. CTI workers, supervisors holding to traditional case management. I think one of the biggest ones was discharging clients at 6 months, provider meetings, and then finally the lack of client follow-up with the resources. And we'll go through kind of how we were able to combat some of these. Next slide, thanks.
So the first challenge that Jessica identified that we're going to dive into a little deeper here, the lack of agency capacity to provide proper oversight and supervision. I did go into this a little bit previously, but one of the important things of determining whether you're going to utilize CTI is, and in fact there's a form for this on the CACTI website, but it's a good idea to sort of determine if CTI is the proper fit for the agency that wants to use it. And there are certain things that are really required to be able to follow the fidelity. And so the question is, does the implementation of CTI coincide with your agency's mission, regulations, funding sources, and I would just say ability to follow the model. So if you have agencies that don't have certain things in place, it'll just make it just makes CTI quite a bit harder to follow to the fidelity. So determine if your agency or program has the capacity to do weekly and individual, weekly team or individual supervision or both, which is what I did, and I think Jessica has done the same. And do you have the ability for your caseworkers to be community-based? This is not a model that's set up where the clients come to you in your office. It's designed to do that. So do you have mileage reimbursement policies, things like that? Do you have the ability for your caseworkers to work in the community with the people participating in the program? Implementing additional tracking tools and paperwork. So it does entail some additional paperwork. It entails some additional meetings, usually more than people are used to having, and to be effectively trained on it. Do you have the time for that and follow up on those trainings? Carolyn's participation in this was really helpful because we had regular meetings to discuss the problems and to work them out and to really support each other in the transition, which do you have the ability to do that as an agency? And do you have the ability to be time limited with the intervention? Some grants are not time limited, right? So they provide case management, or they're described as describing continuous case management perhaps until the need is over. So is it consistent with your agency's mission and the grant's requirements to do that? And again, it's focused solely on making linkages. So if you have certain requirements that you're supposed to do, rather by your agency or your funding source, that may be difficult if you're trying to connect people with linkages. So next slide.
So kind of moving away from the traditional case management mind frame thought process, even the way you term it, right? So you're not referring to the staff person as case management. Instead, because the idea is we're not managing this particular client's case, right? Like kind of just going right in with that title. We are trying to empower the client to be able to do things on their own. So instead, is there a way that we are utilizing different terms, right? So maybe we're, and I forget, I know New Reach had renamed their case managers, but utilizing words like interventionist, liaison, like a specialist, something like that. The other thing that we really tried to do was educate not only the clients, but anybody that is engaging with this program, the differences. So providers, maybe a mental health provider, substance abuse, maybe used to a case manager kind of being that point person for a client, and we're shifting our role. So it's really providing a lot of education. It's also educating a client, right? So most clients are used to, I have a shelter case manager. I had maybe other forms of case management in my life, and they genuinely were the person that did things for me. And instead, we're moving away from kind of the doing things. So a nice example that I always use is transportation, right? So in a normal traditional case management model, we may find that if a client has a doctor's appointment, it's very natural for us to go and pick up the client, take them to the doctor's appointment, and then take them home, right? And instead, through the CTI model, let's empower them and teach them how to be able to do this themselves. Because if we're doing it for them, right, we're transporting them, they're never learning how to get to that doctor's appointment when we're no longer there. So for example, instead, let's go to the client's apartment before a doctor's appointment. Let's print out the bus schedule. And this is all pre-CTI, the example, or pre-COVID, these things I'm giving you. But let's, find out the bus schedule. I'll go with you and ride the bus. Make sure you understand which stops. Make sure you have the right amount of money, and get to the doctor's appointment, right? So I'm going to do it with you, and then you're going to be able to do it yourself. So again, we're kind of empowering clients to be able to do things on their own. Next slide. Thanks.
So it looks like we're running a little short on time, so I'll kind of go through this quickly. And also, this is something we've already mentioned. So one of the biggest challenges, again, was staff, the CTI workers or CTI specialists sort of holding to traditional case management principles. Most of the meetings we had in the beginning, we would have case managers sort of relaying the issues they're having and how they're addressing them. And most of the time, in the beginning at least, it was the CTI worker who was, handling the issue. They were calling, the landlord and trying to talk them out of an eviction, or they were, calling and handling benefit enrollment and all of these things. They were just kind of taking care of it for them. And that feels good. We feel appreciated. We feel like we're making a difference. And it is harder at times to educate or to model rather than to just sort of take over and do it. So that was challenging in the beginning. And so the best way we found to really address that is having the supervisor who solidly understands the CTI principles. So having the staff, for example, just trained in CTI, but not the supervisor is really going to cause difficulty. And then, of course, weekly team supervision to reinforce the principles of CTI regularly, both in team and individual supervision. And then, of course, everyone involved just getting a full CTI training, as I mentioned before, if possible. Just have regular follow-ups, whether that's the supervisor providing a follow-up, or if you can have a trainer providing continual support, is really helpful in those scenarios.
Great, thanks. So I think one of the most common challenges that we heard and maybe still hear is discharging clients after 6 months. Like, how is that even possible, right? And I think one of the biggest challenges, again, going back to this isn't a traditional case management model, is we're kind of used to serving clients forever, right? Like a lot of our traditional PSH models, we serve them. And there's nothing wrong with that. But now we're kind of instead moving away from, we're not the person that is going to do X, Y, and Z, whatever it is, with you forever. And we're giving you the skills to be able to do it yourself. So some of the solutions. The very first thing is, and this isn't always the most liked answer, but it's true, the client success looks different for everybody. And the kind of terming a client stable is also going to look differently. You know, if a client is living paycheck to paycheck, but is genuinely self-sufficient, they're successful. We're discharging them. They're doing well. I think there's a difference between, can you financially afford, you know, a unit and being in rapid rehousing versus you're requiring more service needs, right? So there's a little bit of a difference. And I think that was one of the challenges that came up with rapid rehousing is, do you kind of merge the two? And how do you not, since technically case management, some form of case management is needed to request financial assistance, right? So I'm going to get to that in 1 second. So really, really establishing support systems, linkages, making sure that clients are feeling supported so that you aren't stepping away and just leaving them with nothing. Also, not going from seeing a client every day or every week to not seeing them at all, right? So we're stepping down, and that's where the phases come in. We're decreasing how often we're seeing them. The support system, which I kind of mentioned, obviously establishing that from the beginning. Extensions. So I think, again, going back to that, does a client need additional case management services or do they need more financial assistance? And being able to differ between the two. The nice thing is, through, I think, all of the great work and collaboration with the CANs and Department of Housing, there are mechanisms in place if a client needs more than what rapid rehousing may be able to offer. So that's kind of a whole separate thing. When clients are in rapid rehousing, and if they need more, let's say, financial assistance, but you've been able to discharge them from CTI through this model, we then kind of had this step down process, I guess, where you did that minimum requirement to be able to submit the rental assistance, but you had finished the CTI. So you'd finished the intensity of the services. So kind of knowing the difference between the two. Kind of feel, sorry, I totally stole this from you, Randy. I feel like I just talked about this.
Well, no, that's great because we need
we're running out of time.
we need to get through the rest of these slides. So the other thing I'll mention, we see people typing in questions in the chat function there, in the Q&A function, excuse me. We're going to try to finish so we have time to address some of those. Jessica actually just answered one of them, but we'll try to get those really quickly. So the other thing about combining rapid rehousing with CTI, combining rental assistance with services has its own challenges, because what we started to notice is clients kind of withhold things about income or supports they have, because they know that the more supports they have and the more income they have, it's going to affect how much they need, you know, their portion of rent, or how soon we potentially discharge them from the program, or at least that's what they believe. So combining those two is a little bit more difficult than just doing CTI on its own, for example. And we had to work through that and just strategize and make sure we separated those two things. And there is just quite a bit more, you know, the amount of paperwork for rapid rehousing in my mind is horrendous. It's a lot. And to add sort of the CTI tracking mechanisms and things like that was also a difficulty that we were able to sort of balance through time. And those things, of course, got better after we started doing it for a while. But Jessica, go ahead.
Yeah, so another challenge that we found was the community linkages, right? So really making sure, and this goes with the treatment plan and the goals, if a client isn't a part of the goal setting, they're not going to be interested in achieving them, right? So kind of reevaluating if goals, and I know this was one of the questions, like if goals aren't being met or there's a lack of motivation, then maybe having the conversation of like, well, what is motivating you? What are some of your goals, right? And kind of taking a step back and trying to reevaluate that. What does the client really want? And it may not always be aligned with what we think they should be striving towards, and that's okay. Also understanding the difference between linking a client and providing a referral. Giving them a phone number and then calling it a day is not really a part of CTI. Instead, you're with the client. They're making the phone call, right? But you're there to support. You're going, transportation-wise, right? You're helping them get to those appointments. Maybe you're going through with them a list of questions ahead of time that they want to ask a medical provider or things of that nature. And then it's beneficial for us, and we're going to talk about this in the next slide, but having ongoing communication with the providers. And the last thing I do want to just point out is when we're saying community linkages, it doesn't always mean it has to be formal. So we're referring to any linkages. It could be natural supports, family, friends, church. Maybe they're a part of like a treatment program and they go to groups and they get support that way. It could be whatever. It's some level of support for the client. Okay, Randy, I'm turning it to you. Sorry, guys, we're like flying through these last few.
Okay. And again, Jessica brought these up. So just a piece of advice for the provider meetings. We really need to distinguish between referring clients to resources and actually linking them to the resource. So just essentially you're getting to know the providers, you're getting to know what, the people who provide resources that are common to the population you're serving. And of course, landlords, developing relationships with landlords. If you don't have the landlords willing to rent to the population you're serving, which often includes evictions and criminal backgrounds and things like that are common in the homeless population, it's going to be really, really hard to make rapid rehousing work, let alone CTI. And you're trying to meet with those providers as you're going through the program so that they're prepared for your discharge as well as the client, so that when you discharge, the providers know what their role is going to be and what role you may have served is now sort of backing away. So keeping in mind that you're linking people with resources rather than just referring them, like giving them a telephone number and an agency name. So this is our last slide, actually, we'll go over. So now that we've been doing this for 3 years, what sort of things have we seen? And the first thing I'll see is all those challenges that we listed. Some of them are still present and probably always will be, but they have certainly significantly decreased since the beginning. The CTI teams are really much more efficient at describing CTI, at discharging, at preparing people for discharge. And it just doesn't require as much oversight or training as it did in the beginning phases, as you would expect, hopefully, after 3 years. But in order to do that, in order to see and maintain that growth, I think it's very important that you have occasional refreshers on the principles of CTI, as well as utilizing the tools that are available on the CACTI website, which is the CTI self-assessment tool, which we use periodically. It just reviews sort of all the main points of CTI, and you just score yourself on how you're doing in those places. And it oftentimes brings up things, we haven't been doing that, we really need to pick that up to really follow the fidelity of the model. Just to manage the drift of the program, to sort of back to what people did before CTI, those refreshers and those check-ins are really important. And then Jessica is actually really involved progressive engagement with her process, which I'll leave to her to talk more about.
Yeah, thanks. So for those that aren't familiar, progressive engagement is offering the least amount of assistance and kind of adding from there, right? So it's a lot easier to add case management, financial assistance, intensity, things of that nature, than to give somebody everything and then try to take it away, right? We can't do that. And so after implementing CTI, we then started to implement the progressive engagement model, and we've actually been moving towards enrolling all clients into rapid rehousing for us to kind of assess once clients are in housing, what they genuinely need. It's a lot harder for us to assess the needs of a client when they're in crises, right? So being in a homeless situation, as Randy said, is a crisis of itself. And imagine if it's a cyclical, right? So they've done this more than once, they've been in other institutions, how challenging that is. So instead, we're kind of trying to give them the opportunity to get into housing, stabilize to some capacity and not be in that crisis situation. And then let's assess how long they need. So this is kind of partnered really nicely with the CTI model. And I will say that we have used CTI and rapid rehousing with families, individuals, chronic, our youth. We're actually going to implement more of this into our youth work, and everyone can be successful. So you can utilize CTI with any population that you are working with, and it can be incredibly effective. And most case management models probably utilize parts of CTI, maybe just not to its full fidelity. So hopefully we answered, I think Randy and I tried to answer most of the questions through the presentation. I don't know if Amber, it looks like we missed anything.
Yeah, and just really quickly, the resources. So cceh.org/CTI Rapid Rehousing is a great, there are all kinds of resources there. You can read about what we did. You can see the trainings. They have a CTI training that Carolyn's people recorded. So there are all kinds of great resources there, but also CACTI, which is the Center for Advancement of Critical Time Intervention, is a good website to get things. I saw a question about where can we get the caseload tracker. You can get it from there. I think we also have it on the CCEH Rapid Rehousing website too. So check those websites out. You can really find a lot of the resources there. I think, Carolyn, you actually talked about these things. I guess I kind of took that over for you, but.
No problem. Yeah, please do. I know we're out of time. I just tried to answer one of the questions. I typed it, but that criticaltime.org, you can get to any of us through there. So, you know, if you want to talk to Randy, I can, you know, like, I don't know if your email is on this presentation or yours, Jessica, but you know, all three of us are available for any questions. But if anybody is interested in training for their organization for CTI, please do reach out to criticaltime.org. There is a tab there for training, and you know, we have a group of trainers that are available. So.
Well, thank you all so much. You covered a lot of information in a little bit of time, but you managed to cover it, and you answered all of the questions and answers. So thank you so much, as well as dealing with the technical difficulties in the beginning. But I think we pulled through. I love the CTI model. I think it's great. It's so effective, and I would really encourage you all to look into it for your programs. I've had experience, and it just makes such a difference of really providing effective services, really focused services, and answer so many questions as far as when do I discharge, how do I insert expectations, how much supervision should be provided. It answers all of those, and it's just so easy. So thank you for joining us. We've already answered the questions. So I will say next up, we do have Bobby Watts, who will be doing our lunch keynote speaking on COVID-19, systemic racism, and homelessness. We also have a good amount of we're going to be having McKinney-Vento training, 2-hour training starting at 1 o'clock. We're going to cover when kids experience homelessness. Then you can also join us at 4 o'clock for happy hour. So thank you to all my panelists today, Carolyn, Randy, Jessica, thank you so much. And you all take care. Bye-bye.